Thank you, Mr. Chairman. Senator Johnson.
Thanks, Senator Corcoran. Sorry I was late, so if I ask a question here that's been covered, I apologize. Just in reading the briefing materials here, one of the problems it seems like in these in the demonstration projects is states are moving off way more individuals into these projects than was anticipated. Isn't there a relatively easy fix to that? Does that require some legislation, or am I overstating the problem?
Certainly, there's been a lot of attention on the numbers, and the numbers that are floating around in the public are higher. They're inflated based on what CMS intends to move forward with, and we believe that the number that we control whether we approve these or not. So I think you're right. It's not a complicated issue. There's differences in opinion on how large the size should be. We feel comfortable moving forward with the target that we set. And we do have mechanisms in place to ensure that we will only move forward with state proposals that are appropriate and have the necessary beneficiary protections.
In terms of trying to limit the increase in costs, and I think that's almost about all you can really do in healthcare. Unfortunately, it's very difficult to actually reduce costs. But in terms of limiting the increase of costs, certainly from my standpoint, introducing free market principles into healthcare would be one of those things. Is anything in this demonstration project start moving us in the direction of bringing some free market disciplines? In other words, putting patients more in charge of some of the payments? Or?
At this stage, there's we're not injecting any type of beneficiary payments for this population. We certainly are trying to encourage beneficiaries to be in more efficient systems of care, those that can give them additional benefits than they are receiving today in sort of the fragmented fee-for-service world. And so I think that's the first step toward getting folks more engaged in their care.
So would you say that the cost savings you expect really come more from that coordination of care versus just a capitated type of payment system? Is there any capitation involved in this at all?
Yeah, there's two demonstration models. One is a capitated model and one is a managed fee-for-service model, more like an accountable care organization model. But we think there's cost savings from improved care coordination, from reduction of duplicative and unnecessary spending, which happens quite a bit in this population, and from administrative efficiencies by not having to deal with two sets of program rules and requirements that are completely different.
Are you running those two experiments side by side to determine which is best?
We're not, each state has indicated which model that it's interested in testing. We have two states actually that are interested in testing both models, but they'll be in different areas of the state. So we will have common measures across both models that will help inform the strengths, I guess, and the impact on quality of cost of one model over the other.
If you were to guess, which model do you think would be superior?
We have more stability and predictability in the capitated model and more accountability because one entity is receiving both funding sources to arrange for the care. I think that though that's a more tested model, and the managed fee-for-service model offers us a great opportunity to learn through aligning incentives in a different delivery system setup. And so I think that both have tremendous promise, and honestly, a lot of it just depends on the state and what the state's current delivery system environment is. So I think in some of this, I think that they both hold great promise.
In an earlier response to a question, you were talking about the financial incentives just weren't aligned properly between the two systems. Can you just dwell on that a little bit more, try and get me to understand exactly what you're talking about there?
Sure. So a couple examples. One is Medicaid programs typically have care management programs for high-risk, high-cost folks, but and those care management programs are intended to reduce hospitalizations or readmissions or improve medication management and those things. For dual eligible, if Medicaid pays a care management fee, say it's me, and they pay a care management fee for me, but I'm a dual eligible, so if I have reduced hospitalizations or better drug costs, Medicare gets that money. And so Medicaid doesn't want to make an investment if it has no ability to share in any returns of that investment. So that's one example. Is that helpful? So today, the Medicaid programs are excluding the dual eligibles from these programs by and large because of this financial disincentive, so neither program benefits, nor does the beneficiary. Another example is in between hospitals and nursing homes. So Medicare pays for hospitals, Medicaid pays for custodial nursing home stays. You see this incredible churn between the two payers, largely driven by the misaligned financial incentives. And what happens is the beneficiary gets in the middle, and we have all these unnecessary placements between the two settings, again, in large part because each is paid for by a different payer.
How much does the different reimbursement rates enter into that equation in terms of misalignment of the financial incentives? I mean, are providers pushing more Medicare versus Medicaid because of reimbursement differentials?
It happens for some services. Most of the services, it's pretty clear who's the primary payer, and so there's not as much of that. But certainly Medicare is a better payer than Medicaid, and particularly when it comes to skilled nursing care, nursing facility care, I think there is a greater interest in having Medicare be the payer than Medicaid in those settings.
Okay, well, thank you. Run out of time.